Before I get started, I'm going to get on my little soapbox here and say thank you to Renee for asking the question about what to do when we're transitioning care. And there are some practices in this country which have an excellent transitional care model and clinics built specifically for transitioning children with cerebral palsy to adult specialists, but that is a big deficit in this country in particular, and one that I'm hoping as we grow within the University of Louisville and Norton connection, along with our friends at Fraser, that we will be able to meet these children's needs better as they transition to adult care. So moving right along, we are going to talk about the orthopedic treatment of cerebral palsy. So very briefly, we're going to talk about what we see in our clinics with kids who have CP. We're going to talk about my role and my partner's role in managing kids with CP. I would love to talk about the importance of surveillance, and I capitalized it because it's that important in managing the hip and the spine. And I would like to touch on bone quality issues in kids with CP, as well as gait abnormalities and gait lab testing. So I love this slide because I love being a pediatric orthopedist. And I can say this because I actually practiced adult orthopedics and general orthopedics for 4 years before I came to my senses. In Peds Ortho, we have a toolbox. Our job is never boring. We have lots and lots of ways that we can help kids who have musculoskeletal conditions. Many of our patients have neuromuscular conditions within that group. And I really think that a lot of adult orthopedists have a hammer, like I only do left total hips. And so when all you have is a hammer, everything is a nail, but that's not how we think, and I'm proud of that. It's important that we have a toolbox because, like we've talked about all day today, cerebral palsy is very variable. These are all people with cerebral palsy, and they all have different needs, different levels of function, different desires, etc. And so I'm not going to spend a ton of time on the primary manifestations of CP because, again, we talked about them, but I do want to talk about spasticity as velocity dependent changes in tone that result from hyperexcitability of the muscle. It's important to note that spasticity is dynamic. And in orthopedics, our job should be handling the secondary manifestations of CP, with spasticity prevention being primarily done by our colleagues in PM&R and neurology. And those secondary issues are when that dynamic tone becomes static and we develop contractures of the joints. And we also develop upper extremity deformities. Like Dr. Schuster mentioned, there's a very high incidence of hip subluxation and dislocation. There's a high incidence of spinal deformity. There's a high incidence of foot deformities and gait disorders, and then also fractures. We see fractures being highest in our non-ambulating patients, and those with DEXA scores less than 2 standard deviations below the mean. I like to think of, well, I would love to put myself out of a job on some days because I think that preventing these secondary issues would be very helpful in minimizing the trauma that a lot of these patients have. So preventing fractures, preventing spasticity that develops into permanent contractures. And so an ounce of prevention is worth a pound of cure, and that applies to orthopedics in many respects. So how do we assess these patients? We need to know their level and their pattern of involvement. We need to know their, meaning hemiplegia, diplegia, et cetera. We need to know that the typical joints involved are the spine joints, the hips, the feet, and we need to know how to and what to monitor with those. And we need to know the treatment goals for each level. And while every patient is different and their goals are different, in general, we need to keep our 1s through 3s walking as efficiently as possible. And we need to make sure that our GMFCS 4 and 5 patients are sitting as comfortably as possible. And so the GMFCS, as we've talked about, but we should go into a little detail here, is the ones, those are the nearly normal kids, the ones that independently ambulate. The 2s, they walk independently, but they might need the stair rail, and they have minimal jumping and difficulty on uneven surfaces. Our 3s, they typically walk with assistive devices. An exception might be our hemiplegics. For longer distance, they might use a wheelchair. And our 4s and 5s, they are not community ambulators. They are maybe take a few steps at home and whatnot, but for the most part are in a chair for most of the day. And the 5s are our non-ambulators. Non-ambulators are with global involvement, and they are dependent in all aspects of care. So again, we need to describe the location of their weakness. And I would say that until this year, I have really never seen anybody with monoplegic CP, but I have seen it this past month. It exists. And there's also issues with motor control. Like I talked about, spasticity is one of our primary issues because we don't want it to develop into permanent contractures, but the athetoid and ataxic kids still need us, as do the hypotonic and mixed tone kids. So these kids are complicated, and this picture here of the confused orthopedic resident in my clinic, I like to turn them into confident orthopedic residents who can think of all the tools in the toolbox and how to help these at times complicated kids. And Dr. Schuster mentioned bracing and assistive devices. We have botulinum toxin injections. We have baclofen diazepam. We are going to talk about dorsal rhizotomies, et cetera. But from our standpoint as surgeons, we can lengthen those tendons and tenotomized tendons and muscles that are constantly overactive, okay? We can transfer tendons that fire out of phase and have some element of voluntary control. We can transfer those poorly behaving tendons to areas that are weak and need their help. We can realign hips. We can contain hips with bony surgeries. We can do osteotomies and cut and change the shape and the direction of bones to improve lever arm dysfunction, where kids with rotational or angular deformities have a harder time walking than they would if their bones were in the right place. And we can also use information from Gait lab analyses to guide our single event multi-level surgeries. These are large surgeries with multiple procedures that are meant to minimize the length of rehabilitation and number of anesthetics, and also minimize the so-called birthday syndrome of having one surgery one year and then another surgery the next year and then another surgery the next year. And then also we have spine fusions, which is the most common treatment for spinal deformity. I would also say that as orthopedists, we need to use evidence-based medicine, and there are 2 care pathways that are particularly helpful for us on the AACPDM website, and I would encourage everybody out there to go on this website and look at these care pathways. But the 2 that are most useful for us are the hip surveillance pathways, as well as the bone fragility pathways. So hips and CP, this is a large part of our practice. Hip deformity and CP is anywhere from 1% of kids with spastic hemiplegia who have, say, a GMFCS of 2, all the way to 90% in the spastic quadriplegics. And it results from a muscle imbalance. The flexors and adductors are much stronger than the extensors and abductors. And spasticity increases the risk of dislocation. Spasticity causes hip dislocations, which are painful, which then can lead to worsened seizures, but also potentially worse respiratory function. And kids with CP hips that have a migration percent, which I will talk a little bit about the migration percent in a second, with greater than 30% are at risk, and these are the hips at risk for hip dislocation, which I will call CPHD. And you can see in this x-ray, there is practically the completely vertical proximal femur. The head is stacked right over the shaft, and that is not normal. That's a typical finding. We call that coxvalga, and that also contributes, or is a large finding within hip dislocation in kids with CP. So this is the migration percent. We draw this handy dandy line through the triradiate cartilage horizontally here, And we take the width of this femoral epiphysis at its widest point, that's letter B, and then we divide the part that is of the epiphysis that is hanging out past the acetabulum, that's A, this width A, and we divide A by B, and that's our migration percent. There's even an app for that, the Hipscreen app, which you can get on the App Store. You can use it, hold it up to the X-ray, and just get a quick and dirty migration percent. But I think a large number of us can eyeball the amount at this time. So why is hip surveillance important? You know, for every screening tool, there needs to be a good treatment or a good reason to screen early, to intervene early and prevent worsening disease. And hip surveillance is one of those screenings that actually makes a difference, because early soft tissue surgeries and skeletal hip reconstructions 100% decreases the incidence of hip dislocations and salvage surgeries that have to be done when the procedure is harder, the kid's older, it's harder to bounce back, etc. The GMFCS 3s through 5s can experience a deterioration of motor function that begins in the teenage years and progresses into young adulthood. And we see this in our clinics frequently, which also closely mirrors the incidence of CP hip dislocations along the GMFCS levels. So if you know, some kids have such severe hip dislocations at a really young age that they may need to have a surgery done before the age of 6. And if their bony surgery is done before the age of 6, then they may actually need repeat reconstruction. And so surveillance doesn't stop after that surgery is done. So we watch these kids until they leave us around or before the age of 18. So the stages of hip deformity, we have our hip at risk, which is when their hip abduction is limited to less than 45. And at that time, the migration index may not be more than 33%. And we can do botulinum toxin, we can release some tendons, and we can brace them. Nobody does obturator neurectomies anymore, because that can lead to abduction contractures, which is also not good. And frank subluxation is defined as any hip with greater than 33% subluxation and Shenton's line. So in those cases, if they're young, I still try to keep them contained with bracing and adductor lengthenings. But they continue to have subluxation and that migration index is increasing, then they should undergo varus derotation osteotomies of the proximal femur, plus or minus pelvic osteotomies for any acetabular deficiency. And any hip with a Reimers or migration percent, migration index, whatever you want to call it, greater than 100% is dislocated. And in that case, you might actually have to open the joint itself in addition to derotating and changing the shape of the bone proximally, as well as changing the shape of the pelvis with a pelvic osteotomy. And then kids with windswept hips, that's where perhaps one hip is dislocated and one hip is located, or one hip has an abduction contracture and one has an adduction contracture. You definitely need to treat those. And even if that hip isn't dislocated and you're doing a VDRO, or you need a VDRO on one side and the other side doesn't technically meet the criteria for it, you still have to do both, because it can actually make that windswept hip worse and lead to worse pelvic obliquity, which can then make their scoliosis worse. So I put this little picture here of the AACPDM Pathway on hip surveillance here, just so that you can get an idea that it's a little complicated, but not too bad. And but it's very helpful, particularly for me to know who needs x-rays and who does not. And real basically, we base the surveillance frequency on their age, their functional level, and their gait type, which is the Winters gauge and Hicks gait type. Definitely need baseline x-rays around or even just before age of 2, or when that CP diagnosis provided, or when it is suspected. So I have kids who are 1 who are going to have a diagnosis of CP at some point, I still get their baseline x-rays at 1. And we increase the frequency of our surveillance with the increasing number of their GMFCS level, and also the stability of their migration percent, meaning if it is increasing over time and not staying the same, I will increase my surveillance. And they can be discharged from surveillance at 1 and 2 if their migration percent is under 30% and has been stable. And children with levels 3 to 5, and definitely those with the Winter's gauge and Hicks Gait type 4 hemiplegia, I keep them getting x-rays until they're 18. And anybody else who has a migration percent more than 30%, and anybody with pelvic obliquity that also has increasing scoliosis, because we see the increasing scoliosis drive the hip subluxation, drive the scoliosis, drive the hips, and it's just a vicious circle. So other lower extremity issues in cerebral palsy. Again, this is a picture of a kid who has the more Winter's gauge and Hicks gait pattern type 4, where we have that internally rotated hip, the valgus knee, and these are the ones that are particularly at high risk for hip subluxation, even though they're ambulatory. So real quick, our spastic hemiplegics may have drop foot when they're mild, or true equinus, or jump knee with equinus. And again, it's type 4 gait pattern. And our diplegics also have the equinus, the jump gait, the apparent equinus, and a crouch gait. And here's just an example of gait type 4, although the hip isn't as rotated as it should be. And then here would be more of that crouch gait type look. And here is that kid with the grouch gait who's had single event multi-level surgery to fix his lever arm dysfunction, rotating his tibias forward, making his feet less flat, heel cord lengthening, but definitely helped him with a more plantigrade foot. And there's another crouch gait with a lever arm dysfunction. All right, so again, going back to our tools in the Peds Ortho Toolbox, we have our lengthenings and our tenotomies, our tendon transfers, our hip surgeries, our lever arm surgeries, and our Gait lab. So the Gait lab helps guide, like I mentioned before, the single event multi-level surgeries, or SEMLS for short. And the reason why SEMLS is important is because we want to avoid this so-called birthday syndrome. And here's just a classic birthday syndrome type picture where the kid had equinus, so they got a heel cord lengthening. And then now their hamstring is tight and they're walking in a crouch. Well, we can take care of that. We're going to lengthen their hamstrings. Oh, but gosh, we got their knees straight, but now they can't walk, they can't stand up. So let's lengthen their psoas and get that hip flexion contracture out of the way. When all along, the hamstrings were tight here and the psoas was tight here. And it didn't occur after the hamstring. You just, all your different surgeries unmask the problem. And now, now we have a stiff knee, and now, they're okay, 5 years later. So the Gait lab is supposed to more efficiently and effectively identify gait deviations to create a comprehensive treatment plan. And the advantage of having SEMLS is there's less casting. They can walk earlier, they can rehab better and faster because you're doing it all at once. You have one hospitalization, one anesthetic, one rehab. It is considered the gold standard in neuromuscular orthopedic care, and good improvement has been shown in most gait parameters when systematic reviews have been done about SEMLS based on Gait lab studies versus the traditional method. And here's an example of like all the different things that we can address with a single event multi-level surgery. We can do our pelvic osteotomy and change the shape of the acetabulum. We can do a proximal femur osteotomy and contain the hip better. We can do distal femoral extension osteotomies and take that knee flexion contracture and give them more extension by actually changing the shape of the bone. We can do distal tibial and fibular osteotomies to derotate the leg and put the foot under the knee and make them walk forward in a straight manner. And then for our kids with really flat feet or really, equinovarus feet, we can do some foot osteotomies. And then there's a ton of different muscles that we can lengthen. We can lengthen the psoas, the hip adductors, the hamstrings. We can transfer our rectus or our semitendinosus. We can do patellar tendon advancement, and we can lengthen calf muscles or Achilles. And so in Louisville, there is no formal gait lab, though we have access to other gait labs in other cities and get some valuable data from them. But we also have had, and hopefully we'll eventually have online again. Maybe it is online now, I haven't heard, but we have a GRAIL lab, or a Gait Real-Time Analysis Interactive Lab, which also allows us not only to evaluate the child and how they walk, but we can also treat them using this kind of virtual reality type setup. And there's lots of different inputs. You can have vestibular input, tactile input, auditory input, visual input through this large screen and like almost virtual reality type environment with this dual belt treadmill. And the gait pattern can be analyzed. They can even do an EMG while it's going. And it's captured with 3 video cameras and the integrated motion capture system. And it's also been beneficial for functional gait training in kids who are ambulators. You see, as a harness, so it can be done safely. There's another example of the kid in the GRAIL. And so finishing up with management. Oh, no, this I think is my second to last topic, management of the CP spine. So neuromuscular scoliosis in CP is very prevalent, with 25 to 68% of patients having a formal diagnosis of scoliosis. Again, the risk is highest in our non-ambulators and those with total body involvement. Spasticity, as opposed to like the hypotonia kids and the ataxic kids, is the highest risk for scoliosis. And in kids with scoliosis, that is a neuromuscular scoliosis, there is this classic long sweeping C curve as opposed to the typical S curve of our idiopaths. And CP can be very limiting, or scoliosis can be very limiting in CP because it can lead to, like I alluded to before, pelvic obliquity, difficult sitting tolerance, pressure sores, uneven weight distribution on the upper extremities as well. So non-operative treatment is, again, close surveillance. That's part of the treatment. Getting x-rays is watching the kid and is treating them. We adapt their seating, put paddles or side supports on the side where they have their convexity. We can use bracing to help improve their seating comfort. But there is, and I would caution you all to look at bracing the same in these kids as you do in idiopathic scoliosis. There's no evidence that any non-operative method decreases the risk of curve progression in kids with CP in terms of the magnitude of the curve or the rate of that curve progressing. So I am very careful with parents to talk about how bracing is not definitively the treatment for the scoliosis. And again, surgery, it doesn't prolong life. And there's really, particularly in our severe kids, we have no way to measure the quality of their life or improvements in the quality of their life from having surgery to fuse the spine for bad curves. Nobody has ever shown that it improves hygiene, ease of nursing care, pulmonary status, presence of ulcers, etc. But one thing it has consistently shown in large studies is improved caregivers' perception of the patient's comfort. And again, parents know their kids best, and we should listen to them. And so relative indications for surgical treatment of scoliosis in kids with CP would be curves over 50 degrees in ambulatory patients, And those progressive curves over 50 degrees in patients who are communicative and aware of their surroundings, and curves, that interfere with seating and nursing, and in those where the family is desiring surgery. And those again tend to be the more severe curves, like the 60 and 70 degree curves that we see. So in a patient you have decided to do surgery on, there needs to be a big pre-op evaluation. These kids, there's no such thing as clearing kids for surgery. They should be optimized. We optimize their nutrition the best we can. If they need swallowing studies, they should be ordered. And we need to prepare for blood loss. These curves are stiff. They are difficult to expose. And a lot of these kids are on some seizure medicines, which increase the risk of bleeding. We can use TXA and other blood-saving modalities to minimize the blood loss that occurs. So very basically, the definitive procedure is a posterior spinal fusion. We use what are called pedicle screws and rods. And in kids who don't ambulate, we need to fuse to their pelvis. In kids who do ambulate, we stop the fusion ideally at the lower lumbar spine so we don't interfere with their motion. And very often different levels are required, meaning more levels are fused rather than fewer levels compared to idiopathic scoliosis patients. Intraoperative spinal cord monitoring is performed just like it is in our idiopathic cases, although it is modified because of the kid's neuroatypia rather. And we can also use intraoperative CT, or the O-arm as we call it, for navigation in these kids who very often have severely rotated and stiff curves with abnormal spine anatomy. For very severe hip flexion contractures, in rare cases, you might need to do tendon releases around the hip just to get them in the right position for surgery. And then baclofen pumps may also need to be repaired and reinserted to make way for the spine hardware. So here's an example of a kid with a 118-degree curve. And on the right, there he is with his posterior spinal fusion. Intraoperative CT may be a concern for some people because CT is associated with higher radiation than plain films. But in large studies, the radiation exposure from CT navigation is similar to the amount of radiation sustained in kids having surgery that use conventional fluoro. And it also decreases exposure to us, and it also improves pedicle screw placement, which makes the surgery overall safer for the patient. The surgery, however, is fraught with complications, and it is one of the highest rates of complication, one of the most complicated surgeries, I would say, that we do, with complication rates as high as 62% in some studies. And a recent study showed that this rate is consistently higher than it is in idiopaths, in terms of post-op infection, I should say, and secondary scoliosis. And secondary scoliosis would be like Marfan's or other connective tissue disorders or skeletal dysplasias. The risk of pseudarthrosis, which is incomplete fusion, is 10%. And again, wound infection is very high with 8.7% risk. It's higher when you use allograft, cadaver bone graft. It's higher in cognitively impaired patients and those who are malnourished. And some of that is thought to be due to, hygiene issues, particularly with the pelvic fusions, which have to go quite low and are really near the diaper region in incontinent patients. We may also develop decubitus ulcers or have wound healing difficulties in patients who have already had decubitus ulcers, and then progression of deformity. So fracture management, I'm not going to go into this, but I do want to say that treat like other kids with metabolic bone issues, and consider fragility fractures in kids on anti-seizure medications. There's lots of reasons, but standing programs, vitamin D, bisphosphonates, all can help minimize risk of fracture. And as always, consider non-accidental trauma in these vulnerable patients. Again, Ben Franklin says prevent it rather than try to cure it. Use a standing program, use your AACPDM pathway, and the little green arrow here shows that we need higher vitamin D levels than are recommended in other kids. And again, treatment, this is a plug for our metabolic bone clinic at Norton. It's a multidisciplinary clinic with endocrine and orthopedics. Have them help you. All right. Thank you so much.